so you can see that.
Hello, everyone, and welcome to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the Center for Disease Control and Prevention, also known as the CDC. I'm Val Bias, and I serve as the Chief Executive Officer for the National Hemophilia Foundation. I am pleased to be with you today for our presentation on update on treatment of hepatitis C infection in people with hemophilia, being presented by Dr. Margaret Ragney from the University of Pittsburgh Medical Center. I have a few housekeeping things to tell you, and then we're going to take a poll. But before we get started, here are a couple of helpful hints. You've joined the webinar using your mic and speakers by default. If you would prefer to join by telephone, click on the telephone in the audio pane and then use the dial-in information that will be displayed. If the phone option is chosen, the webinar control panel will provide you with the phone number and access number and audio pin. Give people a minute to do that. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question for Dr. Ragney, please use the questions area in your control panel. She will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. We will begin today's webinar with an audience poll of 3 knowledge questions. Please take a look at the following questions and cast your choice. %of you selected ultrasound every 6 months. The next was B, ultrasounds every 12 months with 18%, and D was the winner, FibroScan every 12 months with 41%. Results on that question were 20% for A, previously treated, experienced, 0 for cirrhosis, HIV, HCV co-infected with ESLD, 7%, pre and post liver transplantation, 0, and all of the above got 73%. A was 6%, B, INR, bilirubin, SGPT was 39%, C, INR, bilirubin, and creatine was 39%, INR, bilirubin, AFP, that's D, was 6%, and E was 11%. Thank you for participating in this pretest, and we will revisit these questions again at the end. Now it's my pleasure to introduce our guest presenter, Dr. Margaret Ragney. Dr. Ragney is the Professor of Medicine and Clinical Translational Science in the Department of Medicine in the Division of Hematology and Oncology at the University of Pittsburgh Medical Center. She is also the Director of the Hemophilia Center of Western Pennsylvania. Dr. Ragney, we are pleased to have you with us here today. Let's begin.
Thank you. I am delighted to talk with you today about a very important topic, that is the treatment of hepatitis C in people with hemophilia. By way of background, hepatitis C is a major comorbid condition for individuals with hemophilia. And while over 90% received clotting factor and became infected before inactivation methods and recombinant technologies were available, the risk of Hep C is now very low, but many people are already infected and at risk for complications. So we are very interested in talking about the really exciting new treatments that are now available for the treatment of hepatitis C. So let me make sure I can. Do I have control of these slides to move them? Oh, good. So I would like to, as an overview for this talk, I have 5 areas that I would like to cover. The first is new antiviral agents. The second is HIV and immune dysregulation in individuals who have chronic hepatitis C. The third is the MELD score and how one predicts end-stage liver disease, which is ESLD, both for HIV positive and HIV negative individuals with Hep C. The fourth is hepatocellular cancer, also abbreviated HCC, if you see that. And finally, end-stage liver disease and liver transplantation. And what I'm going to do is use this as my backbone of the talk, and I'm going to address each of these areas. So first, highlighted in yellow, we're going to talk about the really exciting new antiviral agents. These agents, as we'll be naming them in a minute, but they are effective in those who've never been treated before, which is naive, those who have been treated before, which we call experienced. They work if you're HIV positive, if you're HIV negative. They work if you have cirrhosis or don't have cirrhosis. They even work if you have end-stage liver disease or not. And they also are now increasingly being used both before and after liver transplantation, markedly improving outcomes. The cure rates are upwards of 95%, and in fact, in the clinical trials, if you took the drugs, you became cured. That's amazing compared to what we've seen with previous drugs such as interferon ribavirin. They're also much easier to take. They are oral, they are once daily, and they are well tolerated with no major side effects. And interestingly, there are a number of models that look at what the trajectory of Hep C infection, cirrhosis, and mortality may be, and it suggests in this population, these diseases and complications may really be markedly reduced, if not completely eliminated, by the year 2030. Now, what are these new antiviral agents? Well, you know, they continue to have more and more approved, but I'm going to really confine my remarks to the first few drugs that were approved. Most are very similar. So what you see here is the Hep C protein. And what we are talking about here are the polymerase inhibitors called NS5A in blue and NS5B in pink. Please notice that NS3 and NS4A were what we previously used when we were treating with interferon. Now, and those were protease inhibitors. We're talking about polymerase inhibitors. So in this slide, you can see that if you combine two of the approved drugs, so fosbuvir and ladipizvir, they're very effective against genotypes 1 and 4, and that drug is also known as Harvoni. If you combine sofosbuvir with ribavirin, which is one of the older drugs, it's very effective against genotype 2. And if you combine sofosbuvir with Declinza, also known as decladizvir, it's very effective against genotype 3. And what these drugs do is by targeting two polymerase inhibitor locales or focal points, one is able to markedly reduce the virus and actually completely rid the virus. These polymerase inhibitors are more effective than interferon, ribavirin, or any of the protease inhibitors. They show a sustained viral response in 99%. And in fact, people are not even talking about SVR, sustained viral response. They're talking about cure. They are interferon sparing, which is wonderful. You don't need to use interferon, so you don't have to get all the side effects, and you can feel reasonable while you're taking these drugs. The regimens are much less complex, once a day oral dosing, and they have a very high barrier to resistance. That was a problem with many of the other drugs, and that's why the virus would recur even after treatment. But in this case, these drugs have a very high barrier. In other words, they prevent resistance. There are fewer, less severe side effects. And as I already pointed out in the beginning of the talk, they're effective in those who are naive, those who are experienced, those who have cirrhosis, those with end-stage liver disease, ESLD, and those who are HIV infected. Now, what about the clinical outcomes? Well, we know these drugs, these polymerase inhibitors, rid hepatitis C virus, they reduce liver fibrosis, and they clearly improve survival following liver transplantation, and in some patients, they can eliminate entirely the progression of the disease and the need for liver transplant. One of the most compelling reasons why one should seek treatment early in the course or as soon as possible. They can improve the platelet count. The platelet increase indicates reduced inflammation, less fibrosis, and they can improve overall survival if you do need a transplant, and it reduced rejection of the transplanted organ. In patients without cirrhosis, the sustained viral response is 97%. It's 96% in those with cirrhosis, and it's even as high as 81% in patients who are decompensated. So they have very, very symptomatic disease just before liver transplantation. But how far it will improve the fibrosis, in other words, how much it will reduce it, say if you're one score of a 4 and how low it will become or how low your platelet count will go, are still being studied. We're very early in the game. The thoughts are that these will continue to improve. So really, the critical issues with regard to new antiviral agents is that you seek treatment immediately and early, that you collaborate with your provider, that patients need to talk to their providers about this and to see hepatitis experts, and that you have access to treatment. There is no question that you have, there are excellent cost effectiveness analyses that show that the cost of the treatment for you is clearly supported, that it so much reduces the viral hepatitis and its complications that there's no question that it's cost effective. So it's really a matter of pursuing and persisting with your hepatitis provider as well as your hemophilia provider to get this very critical treatment. Now, the second area that I'd like to talk about is HIV and immune dysregulation, which does affect chronic hepatitis C in co-infected patients. So things we've known for years, not only in the non-hemophilia population, but in the hemophilia population, is that HIV does increase the rate of progression to end-stage liver disease in people with hepatitis C. And it's thought to relate to the fact that HIV causes immunosuppression, and the immune system is very important in mounting an appropriate response to infection with hepatitis C. But what's really wonderful to know is that the treatment of HIV with the highly active antiretroviral therapy, which is HAART, and now sometimes called CART for combined antiretroviral therapy, reduces HIV and thereby reduces progression of end-stage liver disease. So treating your HIV is critical if you're co-infected. It's critical to appropriate treatment of your hepatitis C. But despite the HAART therapy, HIV still can cause other problems, and we all believe they're related to immune dysregulation. And we're talking about early aging, acceleration of cardiovascular disease, as well as chronic bone disease, heart, lung, and neurologic disease. And your health is not completely restored by your antiretroviral treatment because some of the immune defects persist, and this aging process continues to accelerate and may cause premature onset of end organ disease. And again, it's thought because that this relates to the persistence of HIV in various reservoirs, such as the bone marrow and the central nervous system. And there's persistent inflammation as measured by a number of markers such as IL-1 beta, IL-6, D-dimer. But the point is that we really need to have better treatments of HIV in addition to ridding the virus from the bloodstream that will also rid it from the bone marrow and central nervous system. So there have been a number of very interesting studies to look at this. We don't have the answer, but is it possible that it will require both anti-inflammatory agents, even the thought, should you have a stem cell treatment to remove HIV from the bone marrow, central nervous system? These are questions. They are not known. There are a number of very, very brilliant minds engaged and focused on these areas, such as Steve Deeks, who wrote the very interesting article in Nature Review in 2011. But I think these are critical questions that need to be answered to help patients with co-infection. We also know that HCV is associated itself with cardiovascular risk. In the multi-center AIDS cohort study, or the MAX study, one of the 4 sites of which is in Pittsburgh, this was a cross-sectional study of HIV-infected patients, including almost 1,000 with HIV infection and those who were HIV negative and hepatitis C. And what they did was they looked at coronary plaques by CT scan, and it's actually called CT angiography, in both sets of patients who were HIV positive and HIV negative. And what they were looking at is coronary artery calcium, so CAC. It was twice as common in those who were HCV positive, and the plaque was 1.3 times more common in those who had hepatitis C. So cardiovascular disease and coronary artery calcium are higher in those with a hep C viral load greater than 2 times 10 to the 6, so a detectable viral load. The message, the bottom take-home message is one really has to treat one's hepatitis C, whether you're HIV positive or HIV negative, because hep C is a major marker of coronary artery disease and coronary artery calcium, and it may not even be symptomatic. So these are critical things to recognize and to act on. Now, what about HCV and liver fibrosis? There are a number of ways to measure this. One of the most important is the fibroscan, which we're going to get to in a minute, but I also want to make a point that there are some biomarkers that are equally helpful in suggesting the degree of fibrosis and whether a liver biopsy could be helpful. So one of them is the APRI score, and it's simply tests that you do in the clinic or have done on you in the clinic. So the A stands for AST, which is the SGPT. And P stands for platelet. So you have this measured whenever you go to clinic. And what we're saying is that if you make a ratio of the AST to the platelets, that is a ratio that can predict, as a non-invasive marker, not needing liver biopsy, whether or not, or the degree to which you have fibrosis. There have been a number of studies that have looked at this. One of them was the HHH observational study that we did about 10 years ago in hemophilia patients. And HHH stands for HIV infection in Hep C positive patients who have hemophilia. There were 781 of these patients. 25% had F3 fibrosis, which is, it's a 4-score fibrosis measure. So it goes F1, F2, F3, F4. So you had either F3 or F4 in 25%. There was also a meta-analysis done of over 40 studies of over 8,000 patients. And the truth be known, they showed the same thing. And so, for example, I'm showing you this right here. You know, there's a very interesting test called the ROC or AROC test. And what you're looking at is how the two relate to each other. So if you compare the score and fibrosis, so the scores on the y-axis going up and fibrosis on the x-axis going forward, you want it to be as close to 1.00 to tell you that it's really effective. And in our HIV negative on the left-hand side, it was 77%, which is considered quite good. And in HIV positive, it was 82%. But very similar findings. And so, for example, if your APRI score was 1, it had a 76% sensitivity and 72% specificity for determining fibrosis. So you can just have clinic tests done to take a look at what your potential is for having fibrosis, especially if you don't want a liver biopsy. But what I do want to show you on this slide is that perhaps even better is something called the FibroScan. This is a scan done once yearly to look for fibrosis. It's a very reliable measure of fibrosis because what it measures is liver stiffness. You could imagine that if your liver has very few fibers, there's not many sound waves that would bounce off of it and be noted on a scan that measures sound waves, which this does. But if you had a lot of fibers and they got really strong and really tense, it'd be like bouncing a tennis ball off your racket, and it would make a very large sound wave. So actually, the degree of the sound wave gives you an idea of how much fibrosis is in your liver. And what I'm showing you there is how good a measure this FibroScan is. Using a MEDAVIR score on the bottom of that table, you can see F2, F3, F4 fibrosis, F4 being the worst, F3 and 4 being those that have fibrosis, F2 less. You can see that the area under the curves is 97% for an F4 fibrosis, and it's 91% for F3 fibrosis. So this is considered about as one of the most reliable measures of liver stiffness. So the harder the tissue, the more fibers there, the faster the wave travels, the higher the score. And you can actually use this to help determine if you're eligible to take these direct-acting antiviral agents we just talked about instead of getting a biopsy. And in fact, that's pretty much standard of care today. And you can also use it to monitor your response while you're being treated and after you're being treated, or if you are then considered for liver transplantation. So this is a very, very valuable test, and it is one that our hepatologists and hepatologists across the country offer for any patient who has hepatitis C infection. Now, I also want to show you other measures that may not be quite as good, but in sum and substance, they can be very helpful in predicting fibrosis, and these are taken from the hemophilia population. So alpha-fetoprotein is quite good. It is not as good as the FibroScan, but it is a very good measure in patients who don't have any other cancers. It's a very good measure of in Hep C treatment. Age, platelet count, and alcohol use also are measures of fibrosis, but they're not anywhere as good in this study as alpha-fetoprotein, and I think none of them are as good as the FibroScan. Now, the third topic we'd like to talk about today is the MELD score, which stands for Model for End-Stage Liver Disease, and how it's used to predict ESLD, end-stage liver disease. So you may be asking yourself, well, who cares? Well, it turns out this Model for End-Stage Liver Disease has for years been used as a measure of how fast you're progressing to end-stage liver disease and if you need a liver transplant. Now, what it is based on, it was done as part of a very large regression analysis looking at data from thousands of patients with end-stage liver disease. And it gave some very remarkable predictive ability. And what it is really made up of is 3 tests. One is a kidney test called creatinine, in yellow on the bottom. One is a liver test called bilirubin, and one is a bleeding test called INR. And you actually can find this formula I have here, which is really too much to remember, online. If you Google MELD, you can drop in your numbers and calculate your MELD score, and we do that every time we see patients with Hep C in our hemophilia clinic. And the hepatologists are doing it every time they see patients in hepatology. And this is very helpful in predicting, based on the number, whether you're at risk for needing a liver transplant or if your liver is not doing well. So a normal MELD score is about 6. People who have MELD scores above 20 are really having trouble with their liver and really need help from a hepatologist and a transplant surgeon. So one of the things I'd like to show you is it has been for years established that the MELD score predicted end-stage liver disease for HIV-negative hepatitis C patients, but we thought it was critical to know whether it was useful in patients who had HIV-positive liver disease. And in fact, it was the best marker of end-stage liver disease. As you can see here, the hazard of death of 2.6, better by far than the CD4 count, better by far than the HIV RNA-PCR, which is the viral load. And why is that? It's because if you've ever demonstrated that you responded to HIV treatment by improving your CD4 score and your viral load, then it doesn't matter how bad that is at the time you've got end-stage liver disease. It doesn't count. What counts is how bad your MELD score is, and that determines when and if you need treatment by a transplant. So MELD has now been validated as a predictor for HIV-infected Hep C patients as to whether they need to undergo liver transplantation. That's very helpful to know because, you know, for a long time, it was not thought that HIV co-infected patients should even have a chance at liver transplantation. Well, that's no longer the case. Okay, so the fourth topic that I'd like to talk about is hepatocellular cancer, or HCC. So why is that important? I mean, we've talked about end-stage liver disease and fibrosis. How many more troubles can we dream up? Well, it turns out that HCV infection increases the risk, not only of end-stage liver disease, but also of hepatocellular cancer and the death related to that. We know that hepatocellular cancer has been rising for years in many countries, and that includes the United States. Cirrhosis due to hepatitis C, HCV, is the driving force behind the incidence in the U.S. You know, in Asian countries, hepatitis B is much more common of a driving force, but here it's hepatitis C. And it's very important to recognize that that's why hepatocellular cancer is also increasing, because it's related to HCV. And the longer time you've had HCV infection, the greater your risk of hepatocellular cancer. And in each population we study, it's important to look at the incidence of HCC to see whether or not we should be screening for it. Well, we know that the cumulative incidence of hepatocellular cancer in HCV is 2 to 8%. So we also know that the risk is highest in those who have the highest cirrhosis MEDAVIR for screening. So it's very critical that in those patients, they be screened even if they got those wonderful new drugs. And we're going to talk about how you screen for it. It's not the FibroScan, it's the ultrasound. And I want to go over this because it's a critical point for both patients and their treaters to recognize. So, cirrhotic patients who have been successfully treated for hepatitis C, if you clear the virus, you do reduce the risk of developing hepatocellular cancer, but it's not zero. And in fact, we're going to need more studies over more time to truly know when and if it will approach zero. So that the data that could qualify this are not known. There's no evidence yet how good the new drugs are going to be. But clearly, if you took those new drugs and your fibrosis improved, you still need to have surveillance. And it's considered cost-effective until we can show your fibrosis score goes way down, maybe to MEDAVIR 2, maybe MEDAVIR 1. As long as you're still MEDAVIR 4 or 3, you need to have this screening. So the timeline for improvement after you started these wonderful direct-acting antiviral agents, it's still not known. So for that reason, the criteria for monitoring for hepatocellular cancer is absolutely continuing on even if you were treated, and it's the same for HIV co-infected or HIV non-co-infected Hep C patients. The recommendation is to do an ultrasound. The ultrasound is not like your tennis ball. It's not like looking for fibers. It's looking for nodules, which is what the hepatocellular cancer looks like. The best way to do that is by an ultrasound, and you need to do it every 6 months or you'll miss it. The earlier you detect it, the earlier it can be treated and cured. Now, there have been a number of retrospective studies of hepatocellular cancer and risk. In a study of 26 hospitals in Spain, including 167 co-infected patients who developed hepatocellular cancer, what they found was that 39% had already gotten anti-hepatitis C treatment and were, quotes, cured. In fact, 20% developed it after they had a sustained viral response and were literally cured of their hepatitis C. And the mean time from that cure to their hepatocellular cancer was about 28 months. So you can see how critical it is. Even if you've been treated, you're now taking a sigh of relief, your Hep C is gone, the fibrosis is hopefully going to regress, the platelet count is hopefully going to improve, but you're still sitting on a risk for hepatocellular cancer, for which you need to get an ultrasound every 6 months. What they're looking for is a nodule that is there that they never saw before, or it was a little pinpoint before and now it's enlarging. If they find that, they're going to do a lot of other tests. Okay, there's an MRI and a 4-phase CT scan, but what your job is to be absolutely sure that even if you took those wonderful new direct-acting antiviral agents, you get an ultrasound every 6 months so we don't have to see this rise in hepatocellular cancer that we miss. We don't want to miss it. Now, the fifth and final topic that we want to talk about is end-stage liver disease and liver transplantation. You know, maybe those new antiviral drugs are just going to wipe out the need for liver transplantation, but I don't think so. So it's really critical to understand where this is with regard to the chronic end-stage liver disease and with regard to hemophilia. Now, just so you know, in the last 5 years, there was a wonderful observational study supported by the NIAID and led by Nora Terwalt, whose paper I footnote for you. It was of 18 centers with liver transplant patients who looked very carefully for how patients with hepatitis C with or without HIV, which is the H there in yellow, how they did. And they looked, and Pittsburgh was one of the sites. Your site could have been one as well, but this was a very well-run study. There were 266 HIV positive end-stage liver disease patients, 23 with hemophilia. I made sure they calculated that. And 185 who were HIV positive with HCV infection. There were 22 with that. Now, what they found was that HIV reduces patient and transplant survival. By the way, that was known before the study. It confirmed that if you have HIV, even when you're treated, you just don't do as well. And one of the things about this study is they didn't have the advantage of the direct-acting antiviral agents. I would love to do this study again, looking at how well those drugs will protect you once you get your transplant. But what they found in this study was that PWH, people with hemophilia, survived their liver transplant just as well as NH, those without hemophilia. One of the things they found were that people with hemophilia were younger at the time they were transplanted. That's because they've had Hep C since the day they were treated, which is close to their first year of age. So the duration is much longer than any other risk group, such as those who've got a transfusion for other reasons or those who were using drugs. They also had a similar post-operative course, so that if they got the transplant, they survived just as long as those without hemophilia, and that's what you see on the left, post-transplant survival. But what you need to notice is on the right, patients with hemophilia had poorer pre-operative survival. And this may be for a number of reasons. We are doing a study to follow that, which I'm going to tell you about, called the HOT study. But we really don't have answers yet, and we really want to understand this better. What we do know is they had the same CD4 as those without hemophilia. They had the same HIV viral load, the same MELD score. In other words, they didn't transplant them later. They did exactly the same thing. And they had the same causes of death. But what I suspect are two things. Number one, and we're studying them. Number one, they may have had more bleeding problems given a lower platelet count because they have a bleeding disorder, and the duration of infection was so much longer that they may not have been able to wait as long as those in the non-hemophilia group to get their liver transplant. We don't know what accounts for these differences, but I'm pointing out what I just said. They had a longer duration of Hep C infection. They may have had greater bleeding for any given INR or platelet count, and that's therein, I think, the problem, and that's what we thought we should study in the HOT study. This stands for Hemophilia Observational Liver Transplant Study. It's a multi-center, retrospective study of 8 transplant centers, one of which was Pittsburgh, and they had to also have hemophilia patients. In fact, they were the only 8 centers with hemophilia patients in the study I just told you about that Nora Terwalt did, the HIV-TR study. what we did was we requested data from UNOS because I couldn't believe it when I found out that they do not collect ICD-9 or 10 scores for hemophilia. So we had to depend on the centers to use ICD-9 scores, use UNOS data rather than ICD-9 scores. We did univariate, multivariate analysis, and we are in the process of analysis of this data. But the other thing that we have done is we made a formal request to UNOS to please use ICD-9 and 10 scores. They are very interested and are suggesting that they are going to do that. So the ICD-9 and 10 scores for hemophilia will be part of standard UNOS, that's United Network for Organ Sharing, that oversees all of the transplants in this country. So I'd like to just end with a couple slides here about liver transplantation. People with hemophilia are more likely to have bleeding problems than those without hemophilia. They're more likely to have GI bleeding and shock. Have increased sepsis and DIC, increased risk of shock and death, but they still have the same survival rate as non-hemophiliacs, and I believe it's because we treat them with clotting factor. Clearly, factor is related to reduced complications, suggesting to me that bleeding is the source of many of the problems. There are clearly many challenges in co-infected patients. They require excellent control of HIV and of immunosuppression after liver transplant. And in fact, it's clear that survival is complicated, and the major problem there is HCV recurrence, which is why these new direct antiviral drugs are so incredibly important to our current management of liver transplant patients, both before they get the transplant and afterwards, using these direct antiviral therapies. So Peter Stock at UCSF and one of our collaborators and a wonderful transplant hepatologist and transplant surgeon has suggested that these direct-acting antiviral agents need to be used before transplant, after transplant, and to prevent cirrhosis and graft failure. It can prevent post-transplant Hep C recurrence, which is the major cause of morbidity, and it can prevent rejection and graft loss. So that's really what this suggests, that using the direct-acting antiretroviral agents we talked about before a transplant reduces decompensation and mortality. It lessens the time on the wait list and that mortality. It shortens, it avoids some of the donor shortages that are clearly evident. It promotes histologic regression of fibrosis and may actually, for some patients, eliminate the need for transplantation, again, underscoring how critical the direct-acting antiviral agents are before transplant. With regard to after transplant, they allow you to achieve what we would now call cure, not just sustained viral response, before you have your liver transplant, and improve your survival and reduce rejection, and may even eliminate the need for retransplantation, which is not uncommon in HCV-infected patients because of that HCV recurrence. So the data support the use of these drugs before and after transplant. So what should a checklist for the HCV-positive patient with hemophilia include? Number one, initiating antiviral therapy for hepatitis C with these new direct-acting antiviral agents, and you know more and more are coming on the market, but it's hard to argue with a 95% response that we see with the current drugs. You want to monitor your platelets because in patients with hemophilia, once the platelet count falls below 60,000, which it can do in patients with hepatitis C and end-stage liver disease, there's an increased risk for CNS bleeds, for multiple GI bleeds. It's critical that you do prophylaxis with your clotting factors once that platelet count gets below 60,000 to avoid devastating bleeding. If you're HIV positive, there's no question you need heart therapy, and it clearly reduces progression of end-stage liver disease. How should you predict fibrosis? What tests should you do? There's no question the FibroScan right now is among the best tests available. The APRI-score, AFP are ancillary tests to avoid biopsy. They all avoid biopsy. How do you predict end-stage liver disease progression? You use the MELD score. Remember, it's based on the INR, the bilirubin, and the creatinine. It's exceedingly powerful in predicting end-stage liver disease progression and is the measure by which the need for a liver transplant is made. What about if you develop signs of end-stage liver disease? You need to be referred to a liver transplant center, and more, even before signs develop, if you have stage 3 or 4 fibrosis, you should be seen by a liver transplant center at least once. Sometimes it's hard to predict how fast end-stage liver disease will progress. If you're an HCV positive liver transplant candidate, you clearly need to have the direct-acting antiviral agents for Hep C before and after liver transplantation. And what about if you get these wonderful direct-acting antiviral agents? Is your work done? What do we do about you if you clearly have cirrhosis? So that your work is not done. You need an ultrasound every 6 months to look for nodules, to rule out hepatocellular cancer, because it can be cured when it's found early, not when it's found late or in a delayed fashion. So, and I'd like to just end on future approaches in liver disease. Clearly, we need to learn more about what the endpoints really will be if you take direct-acting agents, not just for end-stage liver disease, but also for those who require transplantation. Is there a better way than transplantation? And there are a number of very, very interesting bench studies looking at extrahepatic factor VIII production, in other words, making it somewhere besides the liver, such as endothelial cells, and the use of pluripotent stem cells to generate liver cells. And we even have studies ongoing looking at development of fibrosis regulators. So I think the story is that we're not even done, not even close to figuring the whole thing out, but the best news is we have very effective, very safe, and very well tolerated direct-acting antivirals that clearly can help patients who have Hep C infection in terms of their chronic lifelong infection. And that ends my talk. Thank you so much for your attention.
Thank you, Dr. Ragney, for a very engaging presentation. Now we will shift to questions and answers section of the webinar. Again, to submit written questions for Dr. Ragney, please use the questions area of your toolbar. And we have question number 1. Thank you for your great presentation. For a decade, liver specialists recommended liver biopsies and RBI-INF therapy for people with bleeding disorders and HCV. We now know that the biopsy is generally contradictory for us, and the most reliable evaluation of RBI-INF therapy by the prestigious and independent Cochrane Library found overall no benefit and possible harm. What has the hepatology field learned from this history?
Well, you know, that's a great question, and I think you pretty much underscored it by your wonderful question. It's clear that the gold standard is still a liver biopsy, but it's not necessary. The FibroScan in patients with advanced liver disease, and by that I mean MEDAVIR stage 3 and 4, has upwards of 91 and 97% sensitivity and specificity for a diagnosis of fibrosis and cirrhosis. So we do not need a liver biopsy. It's not needed. The invasiveness is not justified. We can get by with fibroscans, and they are done routinely. The liver specialists in my institution do them absolutely routinely. None of my patients are undergoing liver biopsies, and I might add that even before this wonderful fibroscan, we only did transjugular biopsies, which were very safe, floated down one of the veins, but the point into the liver. But the point, truthfully, is that we don't need any of that stuff, and we shouldn't take any extra risks. And the fibroscan is clearly outstanding.
Question number 2. Are there specific direct-acting antiviral drugs contradictory in hemophilia, counterindicated in hemophilia?
None that I know of. There's actually no reason even to think that might be the case. I'm not sure if this person knows something or has a specific question, but as best I know, those direct-acting antiviral agents work just as well. They're just as effective, just as safe, and just as well tolerated in the hemophilia community as in the non-hemophilia community. And I do know that there is a paper that will be coming out, I believe, towards the end of the year that looks at exactly that question. That is, what was the outcome of direct-acting antiviral agents in patients with hemophilia? And I think you will find that it is identical experience to that in patients without hemophilia.
Third question. I don't have any more. Well, that's Lauren telling me. Anyway, so there are no more questions at this time. Maggie, I'd like to invite you to give some closing remarks.
Well, you know, I think I would have to say this is an amazingly exciting time in the treatment of hepatitis C. I think hepatitis C is a scourge for those who have it. There are not only the problems of the liver in its fibrosis, possibilities of a cancer called hepatocellular cancer, or even the need for transplantation, but also all of the extrahepatic effects, such as diabetes, cardiovascular disease, renal disease, and even lymphoma. It's critical for patients with hemophilia, as with those without, to seek early treatment. It is cost-effective, it is safe, it is well tolerated, and without question efficacious. And it appears to be also exceedingly important for those who undergo liver transplantation because it improves the post-operative liver transplant course by reducing rejection and recurrence of that Hep C. It is also critical to point out there are 2 types of scans we talked about today, and we don't want you to be confused. The first is called the fibroscan. That's like the tennis ball and the tennis racket. The more fibers you have in your liver, the more taut and firm that liver is, and the higher the fibroscan score, meaning more cirrhosis. That should be done once a year in screening for the need for Hep C treatment. We also talked about another scan called the ultrasound. The ultrasound measures nodules in your liver and anything else that is not quite right in terms of mass formation, masses in the liver. We're looking for hepatocellular cancer. This is critical in patients with cirrhosis, treated or not treated, HIV positive or HIV negative, hemophilia or non-hemophilia. It needs to be done every 6 months so that we can determine whether or not you have the beginnings of hepatocellular cancer, because it is curable in the early stages. That's why it's done every 6 months. These are critical to recognize. So for hepatocellular cancer, it's ultrasound. For fibrosis and cirrhosis, it's the fibroscan. And I would thank you for joining us today.
Thank you, Maggie. So my comments would be to encourage everyone to get treated. The NHF MASAC, Medical and Scientific Advisory Committee, recently released a recommendation that encourages or demands that we get everyone with hemophilia treated I believe by the year 2018, because it's possible. So I would encourage everyone, no matter what the obstacles seem, to approach and try to get treatment. Speaking for myself, I found the drugs tolerable and curative. So I would encourage everybody to see your doctor as soon as possible, get involved with these drugs, continue to have your fiber scans and your ultrasounds, because you can recover from hepatitis C, something we didn't think we'd be able to do just a few short years ago. So Dr. Ragney, thank you for a terrific webinar presentation today, and thank you for joining us today on the webinar. And Dr. Ragney, has you advanced to the final slide? I thought you did.
I don't see anything but the final.
Okay. So we would especially like to thank the Hemophilia Federation of America for hosting today's webinar. If you have additional questions about today's presentation, please contact Cynthia Sayers at csayers, that's CSAYERS, at cdc.gov. The webinar will be archived and the content will soon be available at the CDC's Division of Blood Disorders website as shown on the slide. Thank you for joining us today.
Val, should we do the questions?
Oh, that's right. We're supposed to do the questions.
And
Back to the questions for the final round. Pre and post test. Sorry about that, guys. Okay. Question 1B is up. Ultrasound every 6 months now has 73%. Ultrasound every 12 months, 9. Fiber scan every 6 months, 9. Fiber scan every 12 months, 9. Scans only when symptoms develop is 0. So progress there, lesson learned.
Wonderful. The correct answer is A, and you got it.
Yeah. Question 2B is up. A, previously treated experience 10%, B, cirrhosis 0, C, 0, D, 0, all of the above 90%, an improvement there as well. Question 3B is up. The results are A at 8%, B at 8%, C at 83%, D 0, and E 0.
Perfect.
So with that, I'm going to thank everybody again. Thank you to the Hemophilia Federation of America for hosting the webinar. Please contact Cynthia Sayers with any additional questions you might have. That's csayers@cdc.gov. And thank you again for joining us today.